We want to welcome everyone to our third in a series of public online forums about broadband in Central Iowa. And this is all part of the Central Iowa Broadband Internet Study and Survey. And I'm Curtis Dean. I'm one of the consultants that is working on this survey on behalf of the Greater Des Moines Partnership. And the GDMP is basically serving as a coordinating body for this study. It's actually all part of 11 counties here in Central Iowa that have funded and are supporting this through their activities. So I want to thank everybody for joining us today. I'll introduce you to my co-host here in just a second. And, you know, this is one of the important topics that we decided on, the 4 topics we decided on here to have these public forums on. Our first one was on the rural broadband experience. Our second one was on remote education. And our final one, which will be held tomorrow, is on remote work. But today we're talking about remote care, healthcare. And, you know, for many Central Iowans, their first experience and exposure to any kind of telemedicine or telehealth was during the COVID-19 pandemic, when in-person healthcare access became somewhat limited. Now, you know, it appears that people are becoming more accustomed to it, and telehealth and telemedicine are probably here to stay because it does lower costs and can improve access for some patients. So we're going to talk about that today, and in particular, how telemedicine, telehealth are impacted rather by availability of broadband access here in Central Iowa. So welcome to my co-panelist, or I should say co-host, Todd Kilkoff with Kilkoff Advisory Services. He's one of the consultants that is also working on this project. And also want to welcome 3 panelists who can share their levels of expertise on telehealth, telemedicine here in Central Iowa. First off, Benjamin Lefevre, and Benjamin is with Untitled Telehealth. Benjamin, I'll have you explain what your entity does here in just a moment. Is it Vanangs? Okay.
It's Vonix, but that's
Vonix.
Close enough.
All right, K Vonix, close enough for a Monday with fire alarm. Yes, K Vonix is with Aging Resources of Central Iowa, and then we also welcome Katie Winger with Broadlawns, and Katie's the one on mute right now because of said fire alarm.
All clear.
All clear. Great. Well, hey, it's great to have all of you on, and we'll be talking to each of you as we go through here. Those of you who are attendees, we want to let you know that we do have an opportunity to ask questions, several different ways to do that. You can raise your hand using the raise hand function at the bottom of your Zoom screen. And if you do that, we'll be watching for you, and we can turn your mute off so you can ask a question. You can use the Q&A function, which allows you to type in a question. And there's also the chat function, which kind of the same thing. It allows you to ask a question or make a comment. When it's under chat, everybody will see it. So keep that in mind. And we hope to have a good free-ranging discussion there and plenty of time for questions at the end. We've reserved an hour, so we should just get going here. So I want to kind of start with Benjamin, you know, just kind of introduce what Telehealth does.
Sure. You know, Untitled Telehealth is an organization that supports safety net providers on the provider side, as well as on the payer side that provide care to underserved patients, the support they need to implement telemedicine, from technology, you know, video conferencing, to really what's really scaling, and a lot of interest now is around engaging high-risk patients with connected devices in the home. For example, you know, uncontrolled hypertension, you know, connected BP meter, but not just provide the technology, but a lot of ambulatory primary care clinics have a lot on their plate. And so we support them by being an extension with providers that are there to monitor their alerts and do all that stuff to engage high-risk patients. And so we're excited to support really the high-risk areas and patients, you know, in Central Iowa, across Iowa, and across the U.S. To help patients stay out of hospital, engage in better health that are high risk through telehealth solutions.
And Benjamin, I understand this is a kind of a homegrown entity too, right?
Yeah, absolutely. We're headquartered here in Des Moines, Iowa, but working with typically who we worked with and partnered with, again, our safety net providers like federally qualified health centers, rural clinics, critical access hospitals to engage that. But we are here, homegrown, born in Des Moines, Iowa.
Fantastic. Well, Kay, talk a little bit about Aging Resources of Central Iowa and the role it plays in helping healthcare delivery and enabling healthcare delivery for our seniors in Central Iowa.
Aging Resources is the area agency on aging, and we happen to serve Central Iowa, so we serve Polk County and the 7 surrounding counties. But there are 5 other area agencies on aging that serve all 99 counties. So we are primarily a resource for older adults, for people 18 and over who have any kind of disability, as well as their caregivers. So we're primarily funded, we're private nonprofit. We are primarily funded through the Older Americans Act, which is part of the Department of Human Services. We're pretty far down the line, you know, frankly, in the chain of things. But Aging Resources has been here almost 50 years now. Oftentimes we find people don't know what we do until they kind of need us. Our function really is to help people be able to stay in their home as long as possible. So it's our job to know about what services are out there that can help people maintain in their present, in the least restrictive environment.
Great. And I would assume, we'll get more into this later, that access to technology is going to be a very vital element of allowing people to stay in their homes longer and longer.
Certainly. Yeah. There's some really exciting things that are going on right now in the state regarding that. So
fantastic. And Katie, I think probably everyone is familiar with Broadlawns, but talk about your organization and its mission.
You bet. So Broadlands Medical Center is the Polk County Hospital. So we have been in existence since 1924, serving as the safety net hospital to ensure that high quality healthcare is accessible and affordable to everyone, regardless of their ability to remit payment for services.
Great, great. All right, well, we got some people that know what's going on here, from the delivery end of things to the advocacy end of things to the technology end of things. So I want to start out with just, first of all, a little bit of definition work here. Because when I first created this, when we first came up with this idea for this session, I was under the impression that telehealth and telemedicine were interchangeable as terms, but I understand they're a little bit different, and that telemedicine is a slightly more specialized field than, say, telehealth in general. Katie, can you elaborate on that, or any of you, can you elaborate on that?
Well, from our end, we consider telehealth either audio or video calls. From our perspective, it was seldom used pre-pandemic. And obviously everyone had to quickly adapt and incorporate these new ways of accessing and administering care once there were social distancing and quarantine orders being put in place. So, we have found that it's been particularly effective for elderly patients, individuals with disabilities, individuals with transportation considerations, and certainly providing access to individuals within rural communities. But during the course of the pandemic, we could have people who live a block or two from here that would still prefer to use a telehealth visit just for, peace of mind, not being exposed to germs or having to come outside of the comfort of their own home. So for us, telehealth, we've had to adapt as far as appointments, but we've actually incorporated more into our patient portal so that people can communicate with their providers securely. They can check their appointments, their medical records, their medication and prescription history. And just recently, we've rolled out a new pharmacy app so that people can either call in or refill a prescription. I guess it's not calling in if it's with an app, is it? but able to ask the pharmacist questions as well if they have questions about their medications. And again, the key consideration from our lens is making sure that these are secure communications and that they're HIPAA compliant.
Well, that's one of the vital things about telemedicine, telehealth, even more so than some other ways that technology is used to communicate, is that vital need for patient confidentiality, HIPAA compliance, all of that. Benjamin, I would imagine that is a huge element of what your entity, your company does when it's working with platforms to deliver telehealth.
Yeah, absolutely. And just to piggyback on what Katie mentioned, there's a lot of different descriptors of if you Google telemedicine versus telehealth. So there's a lot of different perceptions of the difference. I think the easiest way to look at it is that, certainly telemedicine is what Katie talked about. The telecommunications part is kind of a subset of telehealth. And so think of telehealth as any type of remote engagement, out there. But then when you get into telecommunications or telemedicine, you look at kind of 4 different modes of delivery of that technology. So you have what Katie talked about, kind of the video conferencing piece of it. You have out there, this is under this, Center for Connected Health Policy, a great nonprofit that does a great job explaining the different modes of telehealth. And one is called, would be called store and forward. So think of, sharing an image through a radiologist would view at a later time and bring back a recommendation, or a dermatologist, you send an image of a skin issue and a dermatologist views that and gives back a recommendation. The other one that's getting a hot topic is remote patient monitoring, and then any type of mobile health app tools. But to your point, Curtis, for all of those different communications, security is of utmost importance because you're sharing patient information, PHI, as it's called. And so, any organization, it's pretty standard practice that any platform that's being used for telehealth should be HIPAA compliant, secure, maybe have an independent audit around the security aspect of it. But it's more important than ever because, as you said, Curtis, telehealth is not going away. It's part of how care is going to be delivered continually in the future. And so from a consumer perspective, they should expect that, anytime they're doing a remote engagement, that either the organization that they're partnered with or the technology itself meets all those requirements around security and HIPAA compliance and all of that. And it's really not on the consumer to control that. It's on the providers that are delivering the service.
Has that HIPAA compliance and the concerns about security, has that slowed down the implementation of effective telehealth programs here in America?
Well, it's interesting. I don't know if it's slowed down. I think and probably Katie and would agree, from a broad lawns provider perspective, that, really what's kept kind of telemedicine or telehealth from really taking off is the payment landscape, right? Providers incentivized being able to get paid to deliver, those services. I think anybody that's delivering, there's a lot of choices out there from technology. All of them, you can pretty much feel confident that they're meeting requirements around security and HIPAA compliance and all of that. But again, it's up to the providers to go through that process of making sure that any partner they choose is meeting that. But I would say the biggest barrier or slowdown, and that's been really eased with the public health emergency. Again, horrible experience, but if anything's come out of this is the benefit of telemedicine and telehealth around a pandemic. And so opening up payment and allowing providers to incentivize to do that is really what's either going to slow it down or keep it moving forward.
Now, Kay, your agency is working with some of the most vulnerable Central Iowans, older folks, folks with disabilities. What kind of experiences have they shared with you about their broadband service? In other words, have they shared with you that they've had any connectivity issues that have hurt their ability either to participate in a remote health session or any other thing that can improve their quality of life?
What we've found with a lot of older adults is that they just, they don't even know that they can't get connected. to broadband because they don't have the technology to do that. You know, they don't have computers or laptops or you know, even smartphones many times to even connect with that sort of thing. So there's been some real movement. And actually, I have a personal experience because my mother's 97 and she lives in Dallas County, rural, you know, area, and she's been having some issues with health. And she definitely does not have a smartphone. She still has her flip phone, you know, but she is using now a device called a GrandPad, which is sort of like a big cell phone that doesn't need broadband to connect with people that she accepts. Well, so I thought, well, this is great. You know, we'll be able to do this with her doctor. And, but they couldn't connect through her technology. So it ended up that I had to drive to Redfield to take my equipment out to her so that we could have this telehealth visit with a doctor. And it went very well as far as that was concerned. And other than me having to travel for 45 minutes both ways, it worked really well.
Right. I know I've talked to providers who say it's not uncommon for adult children of aging parents to come into their office and say, I need to get internet hooked up at mom and dad's house. They don't want it, but I'm going to get them connected. I'm going to get an iPad for them and I'm going to make sure I teach them how to use it so that we have a way of keeping in communication, not only for just, you know, chatting and whatnot, but also making sure they're maintaining a level of activity and are plugged into the world. So I would say that, your example is, you know, perfect. I actually have a little personal example too. I just used telehealth here a couple of weeks ago. I woke up one morning with something weird going on in my eye, and I didn't want to drive to my doctor's office and I didn't want to bother him. So I got on the health app and I took a couple of pictures and I sent it to the doctor, and within about an hour, I got a message back saying, I know exactly what that is. I've just called in an eye drop for you. And then of course, another part of telehealth, you wouldn't think of it, but getting a text from my pharmacy to say that eye drop was ready, that's also kind of telehealth when you think about it, because it's using technology to deliver healthcare. So yeah, that's very interesting. So Katie, from Broadlawn's perspective, you know, you're also dealing with some at-risk populations too, because like you said, you're the provider of last resort. You know, Kay mentioned that sometimes older people are less apt or able to adopt technology. Have you found that with some of your patients too, that they don't have the technology they need in their home for you to be able to deliver healthcare?
Absolutely. So about half of our patients don't use email, but they do text. So, you know, we've had to adapt based on what resources our patients use. We had a number of patients that didn't have a smartphone. So through the help of the Polk County Mental Health and Disability Services region, we provided about 50 of our patients with Android phones.
Great.
And then obviously having access to a hotspot or broadband is a consideration too. And so, you know, what we have seen throughout the pandemic is that the digital divide is real.
Yeah.
So one of the things that we're piloting here in the next few weeks is we're going to install a kiosk at Urban Dreams, which is located on 6th Avenue, and trying to get some of the underserved and underrepresented individuals access to virtual technology within a walkable or, you know, on a main bus line. And so if individuals then would walk into Urban Dreams, and that's maybe a more comfortable setting for them than a medical facility, then they can go in and log in and we'll get them access to a provider. So at least from our perspective, you know, that would at least provide a different option than has been rolled out so far. And if it is successful, we have engaged in conversations with the Des Moines Public Library that we might install a similar kiosk at the library. because it addresses the internet, it addresses the technology, it precludes, any transportation considerations for people who live in those neighborhoods. And it also eliminates, that there are still some individuals who have preconceived ideas or, concerns about coming into a medical facility. So that has been something that we've had to really address from a grassroots level here at Broadlawns. And honestly, another consideration is that when people are accessing the appointments from their home, maybe their spouse is working from home, maybe their kids are learning from home. So if people want to have a private conversation with their provider, we've literally had patients going into their bathrooms or their closets so that they can, not have people underfoot or people listening to them while they're on the phone. And, from the provider's perspective, they want their patients' undivided attention so that they can really, be attuned to what are they experiencing right now? What are their concerns? So, there's something to be said too, for coming in person, is that kind of closes off some of the distractions that we all have, when we're within our own homes.
I would imagine. Oh, go ahead, Kay.
Well, one thing that when you were talking about access to equipment and things, the Department on Aging recently received a grant, and Easter Seals of Iowa has used that grant money to purchase tablets and things, plus providing people to actually train and work one-on-one with people so that they can actually use the equipment that's been given to them. And so that is a pretty exciting thing. And a lot of the area agencies around the state have been using technology like that because some of the other area agencies actually do a program that follows people once they've been discharged from the hospital and going home. And of course, the intent is to keep them from coming back to the hospital, to make sure that they're connected to services and so forth. So it's easier for them and much less travel time for their staff to be able to call them on the GrandPad to visit with them about how it's going. Do you understand how you're supposed to take your medicines, and those kinds of things. And it's really, it allows them to see actually how they're doing, which is helpful more so than just being on the phone with them.
Yeah, that's fantastic. Getting resources to the people that need them so that they can get the health care they need. That's absolutely what I can see is very needed in some areas. Talk a little bit about, Benjamin, about what type of connectivity is needed at the consumer level, at the person's home, the patient's home, in order to have a quality telemedicine or telehealth experience.
Yeah, we've learned a lot in our experience in implementing in underserved communities, not just rural, but urban as well. And kind of going back to, Kay's point around, connecting and the different tools, you want to make it as simple as possible. And what we've learned is that, again, if any of the tools require the patient to have Wi-Fi in the home, that's pretty much a non-starter, right? I mean, that's a big challenge. So at that point, then you're looking at, cellular connectivity. And fortunately, in urban areas, that's not an issue. So in most cases, so be able to, as Katie talked through a system, send a simple text message link to the patient that they click on. They don't have to register, or they don't have to input an email address. Work. So, but going back to the connectivity, and typically in underserved urban areas like in central Iowa, where most do have, cell phone connectivity, at that point, you're in good shape to be able to connect for example, a video call, or connect through a connected device like a connected BP meter. Of course, the challenges are in the rural areas where you talked about broadband and cellular connectivity. But if you look at, AT&T, T-Mobile, Verizon, where they're located, yes, there are still dead zones, but they are increasingly increasing the access and connectivity through cellular in the underserved. And most of the video platforms now use pretty low bandwidth to be able to connect reasonably. So in our experience, if a patient does have cell phone connectivity, they're able to connect via cell phone. In most cases, they'll be able to, depending on the solution, be able to connect, for example, through a video call. It's not a win for everything, but at least it still takes away the barrier of, particularly we're talking about the most vulnerable, underserved, low income, having to have Wi-Fi or high-speed internet in the home, which is cost prohibitive. But most do have a cell phone, and if they do have an area where they can connect, now with technology today, you're probably going to be able to have a quality video conference with a provider.
Now, go ahead, Todd.
Are there things that you can't do today because of that signal? And people have just said it's worth the work, it's not worth this feature because we have to increase access first.
Yeah, I mean, it depends on what your goal. Obviously, when we talk about telehealth, in most cases, what's billable and presentable, you have to have that video component. So again, that's the key part of it. Anytime you add in additional tools that take more bandwidth, that's going to make it more challenging the more you have. But when you're talking a one-on-one video consult where the patient consumer does have cell phone connectivity, again, there are areas, dead zones that are not, and still a problem. Typically what we've seen from rural Iowa, rural South Carolina, rural Mississippi, most of them are starting to have coverage from one of the carriers, and at that point, we've seen success in having that video consult. But anytime you add on more, what requires more bandwidth, that certainly decreases the quality of the engagement, and for some areas, that's just prohibitive from connecting in that way, from our experience.
Now, there's also, in addition to provider to patient telehealth, there's also provider to provider telehealth. And actually that's been going on for years. I would imagine there's some really high bandwidth requirements there for certain types of, say, moving MRI images from one location to another so a specialist offsite can examine it.
Mm-hmm. Yeah, absolutely. That's a big area. It's a newer term through Medicare called interprofessional consults, or e-consults, where that is courtesy of provider to provider communication. And like anything else, the more bandwidth or it's needed, whether sending images or whatever, the more bandwidth you're going to need. I think what we've seen in most cases, for example, if you're going from a critical hospital that does have broadband internet to our university setting, we're seeing that those are typically able to connect. The bigger challenge is certainly when we're talking, where we're seeing a lot more in the public health emergency, provider to patient at home, that may be more underserved rural area where we're seeing the bigger connectivity issues. But e-consults, kind of provider to provider, a big area where that started was around Hep C and everything else, just that communication to be able to talk about patient cases and bring folks together. Typically we're seeing a lot of success around those types of communication, but certainly if you're sending a lot of data and information images, that of course broadband and connectivity is just as important for that provider to provider engagement as well.
And I would imagine, at least, I don't want to imagine, I've heard this before, that sometimes some of the biggest challenges are clinics in small communities where access may be more limited than, say, in an urban area like where Broadlawns is located. But you get a clinic in a town like, a smaller community, that it might be a bigger challenge there to get not just the quality or the speeds they need, but also redundancy, because that's a huge issue, well, with any business these days, but it's also particularly a large issue with medical facilities, because if you lose your connectivity and you lose your access to, say, that specialist in Des Moines or Ames or whatever it could be, a big detriment for that small clinic.
Yeah, and I was going to say, fortunately, that goes beyond Iowa, but Iowa is a perfect example of this need. The FCC, the Federal Communications Commission it continues to significantly fund those types of clinics that you described, Curtis, that are supporting underserved patients, but more rural. to support, funding, broadband needs, and the like. And so, again, this, I think the last round, or this round, it's over, it's a significant amount of funding. And so, but they're trying to push it to those clinics that you just talked about, Curtis, to offer support broadband, but not just to do broadband, but then implement, what a lot are calling telehealth 2.0, to be able to monitor patients with a connected device in the home that are high risk around COVID-19, be able to monitor their O2 levels, make sure, uncontrolled hypertension diabetics. But that's the positive of what we're seeing, is that the federal government has really continued to invest in trying to make sure those funds come to those rural clinics and organizations that are supporting the underserved areas.
Seems to me, at least one of the original telehealth applications was the Lifeline service, or Helpline, or whatever it was that I've fallen and I can't get up commercials that everybody remembers so well. Does anybody know, maybe Kay, do those types of services still require a landline phone service, or,
No.
or how do they work?
They've really expanded in the last, I would say, probably 10 years.
Okay.
It used to be that you did have to have a landline. Now they've gone to cellular. You can, some of them don't even have, it's all cellular. There's not even a machine at the home.
Okay.
So it's really improved, I think, and making it more mobile. So because the emergency response systems before, if they were connected to a landline, there was a radius around the home that it would work. And once you got outside that radius, didn't do anything. So it's really helped people get to be more active and to be more mobile, but also safer.
Also, Kay, we have just a tremendous number of amazing senior living facilities here in central Iowa. What kinds of things are they doing to adapt broadband and technology to help their residents, stay healthier longer?
Yeah. A lot of them through this pandemic did use technology to connect the older adult with their family members and things. The social isolation was just horrendous, as we all know. I mean, it's just amazing how that has impacted so many older adults, mental status, as well as their cognitive functioning, even. So we also got a grant, and we're working with Every Step, and they have some technology that they're going to be sharing with those are independent housing, older adults, subsidized properties and things, so that they can do it. They can use it for telehealth. They can use it for social isolation, combating that, either one. So there's some real growth, I think, in understanding how much easier it is many times for someone who is maybe not feeling very well and really should go to the doctor, but just really can hardly imagine dragging themselves there.
Right.
And they may not have transportation. And so then there's that issue. So it's the telehealth is I think is here to stay, I would say. So hopefully.
that's one of the things I was just going to throw out there is, here came COVID. It forced telehealth everywhere. Are we going back to the way it was before, or will it continue to grow as a vital part of our healthcare infrastructure? Anybody can answer that.
Well, I was just going to jump in. Katie can speak from a broad lawns perspective. what we've seen from surveys and data is that consumers really like telehealth. They want it to continue. Kay talked about, the convenience of it. Again, I think the key is, it's just the ability around payment parity around telehealth for it to continue. Again, Katie could speak to that more from a provider side perspective. But we have seen, right, there was a big jump. And when you look at last year during the pandemic, March, April, May, everything switched, to telehealth. You started to see, a decline in just video conferencing use, as it was, but it's not going to go away. It's going to be part of how care is going to be delivered. But I think as we talk about that video piece, but telehealth is more than that. And we talked about being able to monitor falls, being able to monitor patients with high risk chronic conditions, all of that. We're seeing that start to really excel and grow considerably by engaging high risk patients that either shouldn't go into an in-person visit, office visit, or transportation issues, or the ones that are, if they do get COVID, we know are at higher risk for mortality because of their older or chronic disease or what have you. And so be able to monitor them at home makes all the sense. But payment is going to be key, and just providers feeling comfortable with the technology, and of course making it easy on consumers to connect, that you brought up earlier, all have to kind of come together for this to continue to expand, in my opinion.
Yeah, Katie, how does the payment structure work now? Did it change when COVID came out so that providers could get reimbursed for televisits? And is there concern that that'll go back to the old way later?
Definitely. So at the onset of the pandemic, the reimbursement rates were mandated to stay at 100% parity with in-person visits.
Okay.
And that's been extended several times. I know it's being discussed probably as we sit here at the state capitol, and it's a fine line, because I know legislators would like to stay out of the public-private reimbursement discussions, but it's a big consideration. We still have to pay our providers, and our nurses are calling and doing, the triage assessments, and our, front desk staff are still scheduling appointments. So the costs are still there. Mm-hmm. And in fact, I guess I would say that because all of these assessments and registration and paperwork is being processed on the front end, I would say patients are probably getting more time with their providers as far as one-on-one face time. So, I think we're all kind of in a wait and see to see if the Centers for Medicare and Medicaid Services are going to mandate parity in reimbursement, whether the insurance companies are going to continue with 100% parity in reimbursement. We do know that July 15th, the audio only will not be reimbursed at the same level. So we have been trying to transition our patients into virtual or transitioning back into in-person visits. But I agree with everything that's been discussed, that, the pandemic, really, the silver lining is that it has illustrated the efficacy of telehealth. And, in the mental health space, which is a big area of our care, we've seen a 20% increase in show rates. So wow. What it has illustrated for us is that specific to mental health care is that patients really feel more comfortable coming to their appointments while they're still in the comfort of their own home. Mm-hmm. And it really makes sense. If you are anxious or depressed, probably the last thing you want to do is get on a bus, deal with a parking lot, sit in a busy waiting room. So to be able to talk to a provider from the comfort of your own home is a sense of security that we couldn't have really tried to argue in the past. And so it's wonderful that we had this illustration. So, if something good came of the pandemic, it's showing that, people can get high quality care, whether it's video or audio or a combination thereof. It's really effective and it's efficient. Right. So, from our end, we are waiting to see what the reimbursement looks like. I know Wellmark has put forward proposals where they would continue with 90%. And I can tell you, a year ago, since government relations falls under my purview, that wasn't even close to what they were offering. Well, a little over a year ago. So, I think it's a real consideration going forward, is how do we continue to evolve? And, all of us are probably of the age where who would have guessed that, we can hold in our hand a computer,
Right.
versus, I thought I was a big deal because I had a word processor when I was in college. Technology just continues to force our hands to evolve and be agile in how we receive care and how we administer care, how we get information. So as long as we can, continue to provide effective treatment for people and address people's concerns, I think that we're all going to continue to adapt and modify, what have been longstanding traditions in healthcare.
Yeah, and Curtis, I was just going to touch on this another thing, the trend that we're slowly seeing is state by state on the Medicaid perspective, but starting to see it with Medicare and managed care plans is also, transition. So kind of what we're talking about is fee for service, right? That
Right.
model of deliver service. There's a fee, paid for that, and now in that, but we're starting to continue to see that shift to what's called, for folks that understand, basically value-based care, right? Where it's not a fee for service. It's based off, paid on how the outcomes of the patient. As Katie talked about with the public health emerging, it has shown its efficacy in telehealth, keeping patients engaged from being admitted, readmitted, able to follow up. And so that would be a big piece too, is how quick we navigate from fee for service to more value-based care, or how providers contract with payers around value versus volume, type engagement. And so that trend and how fast that continues to go will also tell, how fast providers adopt, these new technologies and way of connecting as well.
Well, one thing I think it's important to understand, you guys understand it, but everybody else should understand, is that even if the price, even if the reimbursement or the payment to the provider is the same, whether it's in person or virtual, the consumer is benefiting from less time away from their job or their children or their school, less transportation costs. And as we all know, transportation also employs risk. So there's no risk involved in driving, 20 minutes or so to a visit. You're not being exposed to others that may be in a clinic that may not be feeling well. So I think there's just so many benefits that it's like a lot of things that we see when we talk about broadband. Is there's so many benefits of broadband that never show up on a balance sheet that people need to understand. It's kind of the same way with remote healthcare, it seems to me.
Absolutely.
Yeah, I've always been an advocate that we need to have a funding stream that pays for these upfront costs in the transition to make sure that people are actually using the technology.
Right.
Just like with broadband, oftentimes we don't have customer service help about how to maximize the benefit. And so then you get people underutilizing just because there's there's not the financial resources to put there. So,
and if you're giving people the choice, that's the other thing too. I think that, I think if healthcare providers said, no, you can't come to our clinic, that would be different than saying, for these things, you can choose to receive that care remotely for your convenience as much as ours. And that, again, empowers the consumer to me.
mm-hmm.
One of the things I wanted to bring up, we've got one comment, and if anybody else has any comments, you can type them in the chat window or on the Q&A button. But one of our attendees said, I think if there was any good to come out of the pandemic, it was the bringing of telehealth, telemedicine, and virtual visits to the forefront. Patients and providers are seeing that telehealth is a great tool and people are willing to embrace it. The pandemic also finally loosened the restraints and restrictions of being able to bill for some of those services, which opens facilities' willingness to participate. I also think the kiosk idea is wonderful. And I'm glad you brought that up, Benjamin. We just had Isaiah from Urban Dreams on our remote education session. And I know he mentioned some of the cool things they're doing there. And that kiosk is a wonderful idea.
Yeah, that's what Katie brought up, and super excited to see it how that goes. And
yeah,
but yeah, a lot of using technology remote. I mean, Katie showed her phone. I mean, an example of a big push from Health and Human Services through an organization called HRSA, which essentially is under HHS. It's called Health Resource and Service Administration, but they're really funding and supporting safety net providers, folks that serve the underserved in rural and urban, for example, that have uncontrolled hypertension. And so take the kiosk idea, or talking about direct to the patient home, have like a connected BP meter that's cellular enabled. The patient doesn't have to download anything. They take the reading and it goes real time to their provider or care team to be able to, if they're out of range, get an alert to reach out to them to figure out what's going on. And so that's one of the exciting things that's really happening, beyond video conferencing, kind of that provider to provider communication you talked about, Curtis, but being really to impact the highest risk patients among us, and or getting, as Katie said, at Broadlawn's kiosks in underserved areas to allow, connectivity and accessibility around that. And so it's really exciting. I couldn't agree more with Jesse. As unfortunate as the pandemic was, it has put a lot of incentive around remote patient monitoring, which is the term for placing a connected device in a patient's home and as well. And so we're in new times, exciting times, but really be able to show the clinical value of providing delivery of care in new ways.
What are some of the real wow things that could happen to make healthcare anywhere easier and better? And what I'm talking about are technologies that, with the proper connectivity, could really, you mentioned some of them, Benjamin, these, ability to have a glucose monitor that's, can be immediately connected to a healthcare provider. What are some of the other things that are out there that feel like science or science fiction right now, but will become reality in the future?
Yeah, there's a lot out there. I mean, again, there's just so many connected devices and so many companies really investing a lot of time and effort in that, just in remote healthcare. And so, but like I said, the biggest one that we're seeing are, our remote patient monitoring, where, the patients don't have to have a Wi-Fi device already comes with a cellular chip built in. And so they just take the readings and off they go. And so but within that, there's just, there's so many exciting different types of devices that you see out there. Certainly wearables is really an exciting area, of focus, where a lot of the big players are putting a lot of time and effort and money into as well. And so, and you're also starting to see the, payers start to invest in tools like this to collaborate with providers, because again, their incentive to decrease hospital admissions and readmissions, from a cost perspective, as well. But I think the most exciting thing that folks are going to start to see more of are the different types of devices to really engage high-risk chronic patients that are at our highest risk for hospital admissions, readmissions, certainly around a pandemic, highest risk for mortality if they were to get COVID-19, and different types of really cool tools and technologies to support those patient populations as well. And then the other key, and I'm sure Katie and Kay, spent a lot of time and effort around this, is that taking technology, but also tying it to what's called social determinants of health, identifying other factors of why folks are, struggling with their overall health, because the clinical piece is just one part, but just identifying, just because of someone's zip code, the challenges that they have in having good outcomes, and kind of taking technology and all that together are some really exciting things that are happening that I'm seeing out there today.
Technology as a tool versus a replacement for the kind of excellent professionals and delivery systems that we already have, and giving them one more tool in the toolbox. That's really cool. I know that I've seen, I don't know if anybody in the central Iowa is using this, but I've seen where they have remote surgery, where the surgeon's in one location and it's a robot arm or something that's doing the surgery in another location. That feels more like science fiction, but it's obviously being done today. Is that something that's a few years away yet, say here in central Iowa?
I don't know about remotely, but we are investing in 2 robots for our surgery department that's currently under construction.
Okay.
So,
Cool.
one of the things that our surgeons have communicated is that, like a hysterectomy can be done on an outpatient basis when you use a robot versus, just a traditional OR setting.
Wow.
You know, we're able to do the anterior hip replacement. Again, some people are discharged the same day or maybe the next day instead of spending 5 to 7 days in a hospital. So anything that shortens your hospital stay is going to provide better patient outcomes, because you're just going to get better rest and quality of sleep when you're not in a hospital setting.
Absolutely.
Well, to say nothing of the, cross contamination sometimes, unfortunately, people in the hospitals are sick,
Yeah.
So
Right.
Yeah.
they can, other people who are maybe a little bit compromised can catch things while they're there that they didn't have when they came in too. But so I'm a fan of this, of no offense, staying out of the hospital as much as possible.
I think everyone would agree with that, even the people at the hospital, right?
Yeah, I know.
Unless you're
Um,
having a baby, nobody really wants to be in a hospital.
That's true. That's true. We'll still encourage that. We need all the population we can here in little old Iowa. We've got to wrap up. We're just about out of time, but I do want to put in a plug for the Central Iowa Broadband Internet Survey, which continues this week. Now, we did extend the survey, but it will be available only through this Friday. And people in all 11 counties are being encouraged to take the survey. If you are a residential, if you live in Central Iowa, we'll want you to take the residential survey and speak about your experiences at your home. If you're also someone involved in business operation, owner of a business, manager, we'd also encourage you to take the business survey to talk about your broadband experience at your place of employment. So that is continuing through this week. To get to this website, you just go to Central Iowa Broadband Survey.com. That actually takes you to this page here on the Greater Des Moines Partnership DSM USA website. And also want to quickly plug our final remote session on our virtual session is Remote Work Challenges and Opportunities. That is tomorrow morning at 10 a.m. Again, go to that same website and you can find the link to that. We're excited to talk about working remotely, the entrepreneurial community in Central Iowa, and how remote, how the connectivity through broadband is so vital to meeting the needs of our remote workers, both the employers and the employees. So thank you, everybody, for coming on. I appreciate our guests, Benjamin Lefevre, Kay Vanags. I said that wrong, didn't I? Again, Vanags, and Katie Wingert, Todd Kilkoff. Even though his name is spelled strange, I somehow always figure out how to say that right. I'm Christine. Thank you so much for joining us. And again, take that survey if you haven't already. Thank you much, everybody.